we have to move on in the interest of time, and also in the interest of topic, to Sophie van Linthout. Sophie has a new professorship, W2, for Experimental Immunocardiology, and as the title already suggests of this professorship, it's cross-disciplinary. It's located in our BIH section for advanced and personalized therapies. And her background, Sophie's background, is on biological engineering and cell and gene biotechnology. She finished her PhD in medical sciences at the famous Catholic University in Leuven, in Belgium. And then she was a recipient of a Marie Curie Fellowship of the European Commission that took her to Italy. From 2004, she worked as a postdoctoral scientist at the Department of Cardiology and Pneumology at Charité, where she mainly was interested in finding strategies to improve diabetic cardiopathy and diabetes-associated endothelial dysfunction. Since 2017, she's a group leader at the Berlin-Brandenburg, now BIH Center for Regenerative Therapies, BCRT, where she focuses her research on experimental evaluation of cell-based strategies for cardiovascular repair. And since now June this year, she holds the professorship that I mentioned with us. Here at the BIH, she focuses on the role of innate and adaptive immunity in the pathogenesis of non-ischemic heart failure, and also again with the final aim to identify actionable targets. So Sophie, great to have you on board, and we're looking forward to your talk, Extinguishing the Inflamed Heart.
So thank you, Professor Baum, for this nice introduction. Also, dear colleagues and dear ladies and gentlemen, so it's a pleasure, but particularly also an honor to be here at the BIH Welcome Symposium. And as mentioned, to talk about extinguishing the inflamed heart. There is more and more public awareness that inflammation plays an important role in different disorders, and that has also been stated as shown here in the Focus cover page in 2018, pointing out inflammation as a silent danger in myocardial infarction, in cancer, as well as in depression. Now, with respect to the heart, we need to go back in time into the early 1990s, and then the relevance of inflammation in heart disease was recognized. One could show that upon cardiac damage, we have a release of pro-inflammatory cytokines, which can directly impair the heart, but also via landing in the circulation, there activate monocytes, which then infiltrate the heart and here further boosting the inflammatory response. And as shown on the right, we can then also, along with that, see that by a worsened heart failure, here indicated by the increase in NeuHA stage from 1 to 4, that when this is worsened, it goes along with an increase in circulating TNF-alpha levels. Based on these data, one wanted then to treat heart failure patients with an anti-TNF-alpha treatment. And as you can see from the graph, this was finally unsuccessful. And further investigations then could show that part of the patients, they did improve, some stayed unchanged, but also by others, even heart failure worsened. So a clear indication that one size does not fit all, and that one needs to come to patient-specific treatments. Now, to allow that, we need therefore a well-characterization of the heart failure patients, and not solely with respect to clinical data, called here in related to phenome mapping, no, also more deeper with respect to biopsies, be it liquid biopsies, but also shown here endomyocardial biopsies, which allow us not only to verify immune cell infiltration via immunohistochemistry, but also via novel techniques, imaging mass spectrometry or single cell nucleus analysis. This can all be done with the endomyocardial biopsy, and even we can here also isolate cardiac fibroblasts, to which I will come later on. But I wanted to come back to the point that if we think of heart failure, that there it's related to see it as a multi-organ syndrome, and related to that also the inflammation, that so it does not only affects the heart, but also the other organs. Now, in the coming minutes, I would like to guide you through some experiment studies which we have done in the past, and those what we are currently doing, and also those planned in the future. And as Professor Baum already also mentioned, I focus particularly on the innate immune system. And in that context, we could show in endomyocardial biopsies the increase of a specific receptor calling the NOD2 receptor, which is a pattern recognition receptor, recognizing Coxsackie virus B3. And interestingly, this expression was increased particularly in myocarditis and inflammatory cardiomyopathy patients, which were Coxsackie virus B3 positive. And that then further gave us the idea to now to look at the relevance of NOD2 in myocarditis. And for that, we went to NOD2 knockout mice, and we could there then see that finally the NOD2 knockout mice, that they were rescued from the detrimental effects from the virus, shown by a lower presence of CD68 cells, lower cardiac fibrosis, and also a decreased level of NLRP3, which is downstream the NOD2 pathway. Now, this further inspired us to look for a therapy and to block NLRP3, and here we landed by colchicine, which is a classical microtubule inhibitor, but due to the inhibition of the microtubule polymerization, it affects that the assembly of the NLRP3 is blunted, and by that means the NLRP3 activity. And for that, we now went back to the mouse model of Coxsackie virus B3 induced myocarditis and treated them with colchicine. And you can appreciate that the treatment led to an improvement of left ventricle function, here shown by DPDT max, as well as a decrease of interleukin-1 beta positive cells. And finally, all those data now resulted in the fact that a multi-center trial can be started, where with a principal investigator Carsten Schöpe, and here granted by the DFG. So an example from going from the bench, from the bed to the bench, back to the bench. So here a translational example. I see it also as another example of going to repurposing strategies, in the sense that colchicine, via its action of blocking the NLRP3 and the knowledge that NLRP3 activation plays an important role in breast cancer progression, but also in doxorubicin-induced cardiomyopathy, that via this means we can here check now whether by using colchicine we can here perform a dual intervention, and this is now also currently running in frame of the comeback study of the sponsored by the BMBF. I mentioned here now examples of myocarditis, inflammatory cardiomyopathy, also doxorubicin-induced cardiomyopathy, which are examples of so-called heart failure with reduced ejection fraction, where the initial stress is coming from within the heart and leads then to the specific eccentric remodeling. But one needs to know that in heart failure, I mentioned it's a heterogeneous population, that 50% of them with so-called heart failure with preserved ejection fraction. And there, in contrast, the initial stress trigger comes from outside the heart, be it a pro-inflammatory state, a low-grade inflammation, or also called a meta-inflammation. And it is this study of cardiac versus extracardiac inflammation, which I now will further investigate in frame of an SFB, which is now recently been approved and led by Professor Birgit Pieske. And here I will investigate particularly again the innate immunity, alarmins, NLRP3, also focused on gender and sex differences. And again, also here, look at and investigate the endomyocardial biopsy, but as well using mouse models, knockout mice, and also rescue strategies via AAV transfer. Coming now to the fibroblast. And if we think about the heart and inflammation, then one needs to say that lots of studies have been performed studying the infiltration of immune cells after the cardiac damage, and then also how this then leads to the activation of the fibroblast and subsequently to cardiac fibrosis. Now, what is less appreciated is how now the fibroblast on its turn can affect the inflammatory response. And this can be done via the fibroblast. It affects, it can release chemokines, it can induce adhesion molecules, also promote transendothelial migration, and it is the most important source of NLRP3 inflammasome activity within the heart. Now, we studied further the fibroblast, and what we did is we checked now the influence of the cytokine environment on the fibroblast activation, and check this now also with respect to interferon gamma and TGF-beta, and also how those cytokines, which subsequently are finally released in the heart, how they affect the fibroblast activation. Then you can appreciate that upon interferon gamma stimulation, this actually does not lead to collagen increase, but that it leads to a raise in chemokines which attract the pro-inflammatory monocytes as shown here on the right. And that in contrast, when we stimulate the fibroblast with TGF-beta, that this leads to an increase of collagen production, and related to the chemokines, more to chemokines which attract the anti-inflammatory monocytes as shown here on the right. This indicates that in heart failure, when we have activation of inflammatory cells, that they can activate the fibroblast, leading to more collagen production and cardiac dysfunction, but on its turn, that the fibroblast can further modulate here the inflammatory response, and that it can also, in that context, may also lead to a chronic inflammation. Now, this is only one aspect. We may not forget here also the impact of mechanical stress on the cardiac fibroblast, where it is known that fibroblasts, when they are stretched, that they not only produce more collagen, but also the chemokine MCP1, which attacks the pro-inflammatory monocytes. And in a proof of concept, we could show in a patient with fulminant myocarditis that if we here decrease the load via insertion of an auxiliary pump, that this goes along with a drop in immune cell presence, as well as with a modulation of the extracellular matrix. So pointing out that the fibroblasts, they are patrollers of cardiac homeostasis, involved in fibrosis, but also in inflammation, and maybe also in regeneration, what I will not here talk about today. So in that sense, fibroblasts, they can be a biomarker for prognosis. They can be used for specific extracellular matrix modulating therapies, as well as a monitoring marker. And for that, we are capable now, as I mentioned, to isolate the fibroblasts from endomyocardial biopsies via an outgrowth culture. And here we could already show that we do see differences among the kind of heart failure, be it heart failure with preserved ejection fraction or heart failure with reduced ejection fraction, between male or female, basal, but also upon stimulation with TGF-beta. With respect to the mechanical stress here in the project of the BCRT Mechanocard, here we will now further in detail evaluate the impact of inflammation and load in patients, and we investigate this locally, so on the biopsy, but also systemically via peripheral blood mononuclear cells. On organ level, the biopsy per se, but also on cellular level, the endomyocardial biopsy, derived fibroblast, and here, importantly, in cell culture, in the presence as well as in the absence of load. And with bridge to bone, we will also perform experiments with mesenchymal stromal cell cells from the bone marrow here to compare also the immunomodulatory characteristics. So this all in frame of stratification, of finding model systems, and also of prognosis. As mentioned, this is a teamwork led by myself, but with Carsten Schöper for clinical aspects and expertise in hemodynamics, Oliver Klein for spatial proteomic signatures, as well for matrizome composition, and Ansgar Petersen, which you will hear later, specialist in mechanobiology. And in frame of this study, we will also here, of course, also look at the heterogeneity of the fibroblast via single cell sequencing. Now, this is the characterization of endomyocardial biopsies, but we will also look at the skin as well as at the skeletal muscle-derived fibroblast. And this is all with patients, but here to give already an indication, now going to the mouse. Here we already evaluated first data with comparison of left ventricle versus skeletal muscle-derived fibroblast, where you can appreciate differences already in the composition of the extracellular matrix, as well as the release of chemokines being here higher in the skeletal muscle-derived fibroblast compared to those of the left ventricle. And in frame of the comeback study, as mentioned before, we will do also here a comparison of the left ventricle versus tumor-derived fibroblast. Why is this organ-specific characterization important of the fibroblast? I believe that this is needed to understand the organic specific responsiveness to one common systemic inflammatory environment, and to develop also organ-specific extracellular matrix modulating therapies. And finally, also to understand the efficacy of repurposing therapies, but also off-target effects. With that, I want to conclude that to target the inflammation, we need to understand the cellular mechanisms. We need to work in an interdisciplinary manner. For that, we also need to differentiate the patients to finally come to translation. And clearly, these teams are interconnected. So with inflammation being here the target involved in heart disease, we have an involvement further of the immune system, which here also interacts with other organs. Again, arguments for working in an inter or transdisciplinary manner, which is here available at the BIH. And here I see the fibroblast as an important target cell, also in view to form or to look for specific anti-inflammatory or immunomodulatory strategies. And with that, I'd like to thank you for your attention.
Yeah, fine. Applause also to you from everybody here in the audience. We can't hear it, but we can imagine it. And this was a very clear presentation. I haven't seen a question coming up so far. So my first question would be similar to the one that I asked with Sarah Hedry's presentation. Do you consider fibroblasts to be a homogeneous population, or do you have any single cell data to distinguish certain classes of fibroblasts?
So clearly fibroblasts are a heterogeneous population, and that's what we are going to intend to do, to perform single cell analysis. We've seen in other studies not related to the heart, but also looking over by rheumatoid arthritis, for example, that there are differences, for example, in CD19 positive fibroblast activating proliferating cells, that they have, for example, inflammatory properties, whereas others, they have, again, they're in that context more effects related to erosion. So one needs really here to find the clusters to also be able potentially to specifically target the right fibroblast. And we need for that to identify them and to see also this is more than related to the pathogenesis, but also that what we know also from other organs, this can also be a spatial event, so that we all need to get further insights to get for our understanding in cardiac remodeling and cardiac fibrosis, as well as for inflammation.
Yeah, thank you. Thank you, Sophie. Good luck with all this beautiful work.